Today's session is going to focus on disaster preparedness for CMC, lessons learned from the Texas winter storm of 2021, and it's going to be presented by Dr. Adam Rosenblum. Dr. Rosenblum lives in Austin with his wife and children. He received a master's in public health from Boston University and medical degree from Ben Gurion University. He's trained in pediatrics, and he trained in pediatrics in Austin and served as chief resident. He has been a complex care pediatrician at Children's Comprehensive Care, a primary care medical home for children with medical complexities since 2015. Dr. Rosenblum, I'm going to turn it over to you.
Well, thank you, Amy. Thank you all for having me. We are definitely excited to share our experience with the great Texas winter storm of February, what our experience personally and professionally was during that time, and really start a conversation about thinking about disaster preparedness for this special population that we care for. Next slide. So I have no financial relationships with any manufacturers or any commercial products that I won't be presenting about today. So, we're really going to talk about some of the practical challenges, some of the considerations for children with medical complexity during this disaster and preparing for future disasters, as well as all in the context of a global pandemic. We're going to talk about some of the lessons that we learned at our clinic. Next slide. So really just an overview, disasters really come in many shapes and sizes. Some can be somewhat forecast, like storms, or seen from afar, like wildfires or floods. Some might happen all of a sudden and give us a very short time to see coming and prepare, like earthquakes or landslides. The kind of cascading effect of these kinds of disasters, like causing things like systems breakdown and power outages. And of course, there can be disasters that happen personally, like the loss or death of a caregiver. So I think it's important to really talk about some of the pre-existing conditions that make talking about this population of children with medical complexity more vulnerable during disasters. You know, there's this socioeconomic determinants of health, the poverty that kind of works in both ways in this population: food insecurity, insecure legal status. The medical complexity of these children kind of puts them already in a place where they're already sort of on the edge of a crisis. When we talk about technology dependence in this population, what we're also really talking about is power dependence, and many children are also water dependent, potable water. And I think that what became quite clear is that all of the children that we care for, children with medical complexity, may be defined as children that are dependent upon systems working. And during disasters, those systems break down. Next slide. And so then, of course, there's also been a lot of challenges in this last year during COVID-19 with delays in access to care, with school closures, and a lot of the services that children with medical complexity receive at school being unavailable, the mental health effects of both the children and the families that care for them, a lot of the economic considerations around working and job insecurity during this last time, and that children with medical complexity may need different accommodations for how they're tested and treated for COVID-19. So we're going to talk about Winter Storm Uri, which occurred during February 13th to 17th. This is a screenshot of my phone. My parents live in Hyde Park, Vermont, and it was the same weather, same degree of coldness in Austin, Texas, and Hyde Park, Vermont. A parent had emailed me as I put out my comments on the listserv that this was by far the most traumatic event that we have undergone during their child's life. Keeping him alive was our primary focus, and it took every bit of energy and skill that we had. So just a little bit about our clinic. You know, we were established in 2012. We are a primary care medical home that cares for children with medical complexity. We serve right now about 850 patients. About half of our patients are G-tube dependent, 10% are trach dependent, 5% are vent dependent, about 40% are Spanish speaking only. About 2/3 have reported in the past significant financial stress, and by 1/5, we would classify as food insecure. So just to give you an idea of what had happened in Texas and across the country in February, you know, starting on Saturday, February 13th, we started to get some cold rain. By February 14th, that rain had turned into heavy snow, and the temperature plummeted to about 5 degrees Fahrenheit, which is extraordinarily cold for Austin, Texas. And we began to receive about a half a foot of snow that stayed on the ground for about 5 days, which was a record. We had a record 44 hours of freezing weather. In Texas, there are a lot of uninsulated houses, a lot of heat, depends on power, and beginning Sunday night or early Monday morning, the power went out. And about 4.5 million people across Texas had lost power, and that power did not come back until really Friday, or in some cases even later. They were described as rolling blackouts, but for many had lost power that never came back. The roads were completely covered in snow and ice, and we do not have plows to clear them. We do not have snow tires or chains. We don't have all-wheel drive cars, although there are a lot of trucks in Texas. But driving was very, very dangerous, and so many roads were closed. There really were car accidents everywhere. There was a 26-car pileup on I-35, the main thoroughfare through Austin, Texas. Everybody was dripping their pipes to prevent bursting pipes, and that really caused a major freshwater crisis in Austin. We were using 2.5 times the amount of water that we typically did, and so both water pressure plummeted and also pipes burst. Water treatment plants went offline because they did not have power. So fresh water, potable water out of taps became unavailable, and a boil advisory effect went in for 29 million people. Many people's tankless water heaters broke, and so they also didn't have hot water. Many people didn't have heat, and firewood was very difficult to find, even if you did have an indoor fireplace. People resorted to burning objects in their homes. Our local children's hospital lost their water pressure, and their boil advisory contaminated all of their pipes and their water fountains. Our children's hospital resorted to bottled water and toileting in hats and disposing of that in biohazards. Hospital staff were sleeping in conference rooms in the auditorium. Schools closed, businesses closed, restaurants closed, pharmacies closed, supermarkets closed. Open corner stores were quickly emptied of their perishable foods and then their non-perishable foods. Food banks were closed, WIC was unavailable. Those with only electric stoves were unable to cook food. The ability to pay for things with debit cards and credit cards was unavailable, so only those that had a significant amount of cash were able to really even purchase anything. Therapies closed, home health nursing was unavailable, personal attendants were unavailable, DME support was unavailable. Hotels quickly filled up, and then some lost power. Our Ronald McDonald House was out of power and water. And all of this was, of course, within the context of a global airborne viral deadly pandemic. And at that time in February, Austin was at stage 4, its second highest threat level. So in the end, about 111 people, at least in Texas, died to house fires, carbon monoxide poisoning, automobile accidents, and cold exposure, including an 11-year-old boy north of Houston. There was an estimated $200 billion of damage, and the recovery, of course, is still ongoing. So it was a real major disaster. In preparation for this talk, I asked a promising and up-and-coming complex care pediatrician, a third-year resident, Dr. Yuan Trong. Remember that name? Hire this lady. I asked her to interview everybody at our clinic about their experience during this week. And so really then their thoughts are distilled into the following 8 big lessons that our clinic learned. So the first is really vulnerability begets vulnerability. You know, the systems that we build are interdependent. Logistics and food depend upon transportation, water depends upon power, and our work depends upon communication systems. And what really became clear during our experience during the storm is that these systems are interdependent, and they fall like a house of cards, and that failure of systems cascade. And that's a lot like the morbidity that we're quite familiar with in caring for children with complex medical problems. The second big lesson learned is that families are responsible for preparing themselves for disaster. So disaster preparedness takes time and money. It takes executive functioning. It takes a web of support. And the families that we work are really hard pressed to prepare for disasters. What became clear during our experience is that we had made assumptions that government or business or nonprofit organizations were going to come to our rescue during these disasters, but it didn't happen. And we realized that our clinic, our medical home, and that the families that we care for, we collectively were responsible for preparing for disasters and responding to them. And I think we were mistaken to think that this kind of work was not part of our mission. Next slide. The third big lesson learned was that a safety net that we depend upon that operates well during normal times really collapses during crisis. So the systems that we've built to help these kinds of families through hardship, such as food assistance or transportation assistance, peer support, attendant care, these kinds of systems were not built to withstand the shock of a large-scale disaster, and that children with medical complexity are dependent upon systems that work. We've built these complex systems, and they got many moving parts. We have many participants that are part of it that are working just in sync to deliver care. And these systems are designed for a just-in-time kind of delivery of their resources. DME and medicine are all dispensed as just enough. And the systems are not built to absorb a large shock, and that children with medical complexity live on the edge. And it didn't appear like it took a lot to push these families into a big crisis. The fourth big lesson learned is that the ongoing work doesn't get waived during a crisis. We all know that chronic care and all of the work that's included in it, the mountain of bureaucracy that helps it churn, has this incredible amount of momentum. And some in our clinic found it really kind of difficult to turn this huge, heavy ship. Our clinic completely shut down for a week. We weren't able to see any patients, but sort of the paperwork churn continued. And there were questions about when should we just drop our ongoing mission and recognize the gravity of the response that was required and completely shift to a new frame. The disaster response really took a whole new effort. Roles changed. Staff members were performing tasks that they'd never had before, and it caused a delay in our ability to get going, I would say. The fifth big lesson learned is that the resources that were existing weren't really nimble enough. And I give this example of a regional insurance company offering to pay for hotel vouchers. But by the time the process that was required to get hotel vouchers approved, by the time that found their way to the families that we served, really all of the hotels were already booked. We didn't really have a community plan to to keep families and children warm, to recharge large numbers of technology-dependent children. Our hospital was overwhelmed. They were not able to admit the 50 event-dependent patients that we had. And so our disaster response systems are are not really built for children with medical complexity. They're built for healthy people and able-bodied people, and oftentimes people with resources. Next slide. So big lesson number 6 was that we weren't imaginative enough about how much could go wrong. Really, our story was a cautionary tale. We saw the storm coming a week away, and we thought it was curious. You know, it had snowed already once this winter. It's always interesting when it snows in Texas. And we did the things that we thought we should do, like cover our pipes and cover our plants, but we never thought that it would devolve into such a crisis. We never thought that all of the infrastructure would completely collapse. And so we didn't prepare. We didn't make sure families were prepared. And then when the crisis hit, of course, we were completely caught off guard. And so in a sense, this crisis, even though it was forecast, was a lot of like the sort of all of a sudden abrupt crisis that that might be like earthquakes or tornadoes. It still kind of came all of a sudden. But I think, frankly, there was a growing realization among our community that what we experienced would not be just a one-off, that climate shocks and infrastructure shocks will be experienced again and again. And that I think our imagination and our work really needs to match that reality. Lesson number 7, you cannot prepare for a disaster during a disaster. And frankly, it's difficult to respond to a disaster during a disaster, to overcome all of the logistical challenges to meet the needs. For our clinic, it was really difficult to mobilize because we ourselves at our clinic were also suffering from the effects of this collapsed infrastructure. We also didn't have power or water, or our children were not able to go to school. And so it probably bears repeating that the most effective way to respond to a disaster is to build a resilience to it, to fortify that personal resilience, but also build the systems that can absorb these kinds of shocks. Build systems with individuals with disabilities in mind, and rather than individuals with disabilities sort of being an appendix or a patch or an add-on to existing disaster planning. And lastly, the lesson learned number 8 was that community support was critical. You know, in our response, there was a sort of a paralysis to this overwhelming trauma. There was a helplessness of what we could do to help these families. And I think it was important not to try to start with the premise of taking on the whole problem and trying to solve it all, but to just start from the bottom about counting what we did have, what resources we did have, and the resilience that we did have. Even if it was small or insignificant to the scale of the problem, it could sometimes just be this catalyst that gets us going, gets the wheels moving. And so next slide. I'll just speak a little bit about personally what my personal experience was during this week. Like most in my community, I was without power or potable water, and unable to charge phones, communicate with the clinic. We were basically winter camping in our living room in 10-degree, 20-degree weather in front of the fireplace with my family of 4. Like most, our food plan in our family is a just-in-time delivery, and when that didn't arrive on that Monday because it was unable to be delivered, we were low on food. And finally, when I was able to get back online and in touch with my clinic on Wednesday, it took a couple of days. I found that the nurses were already beginning to develop a list, a needs assessment of who was food insecure, water insecure, what were the needs of our families. And so we began to get to work, and my wife and I started calling restaurants, asking them if they were still cooking. And the effort kind of slowly snowballed to a much larger scale effort of recruiting, and we can go to the next slide, recruiting recruiting a team of drivers and connecting them with a dispatcher, telling them where to go, connecting them with restaurants that were still cooking food, connecting them with a donor like World Food Kitchen that was paying for meals that we could deliver to the families that we had identified in our clinic in need. And so over the course of Friday, Saturday, and Sunday, and thank goodness the roads started getting better as the temperature started warming up and we were able to start getting out there and moving and helping families. We were able to deliver 3,500 meals and also water to over 100 families. This map you see is the map that we created of all the families that we served. This picture is one of our recipients. And so it was an uplifting and mobilizing kind of endeavor that included a lot of the members of our clinic, but also a lot of people in our community that were eager to help, but needed the organization to get out there and help families. So the big takeaways are, of course, be proactive. Think about this problem. Know that it's not being thought for you, and that it's very difficult to respond during a disaster. There are a lot of resources in the internet about what should families do, what kind of preparations that they should make, what should go in go bags, what's on the list of things that families should have available. Plan for what your clinic will do and how your clinic will be affected by a disaster. Think about what we already have, leverage our community resources, start from what resources we do have, the resiliency we do have, and think about the entire experience of that children with medical complexity interface as we plan for how to respond to these kinds of shocks. Next slide. So here are some of the resources. Amy, are we going to have a discussion first or go straight into our case?
We'll have a discussion first.
Sure.